Welcome to the deep dive. Today we're tackling a condition called ascending cholangitis.
That's right.
Picture this.
Yeah.
You've got these tubes, the bile ducts, kind of like the body's plumbing for digestive juices, and they get blocked up. So instead of everything flowing nicely, you get this stagnant pool, and, well, infection can start brewing there.
Exactly. And these ducts are super important. They carry bile from the liver to the gallbladder and then down into the intestines to help digest fats.
So a blockage causes a backup, and then infection sets in.
Pretty much. Think of it like a blocked drain in your house. Things can get, well, pretty nasty when stuff can't flow through.
Right. So our mission today is to take some detailed revision notes we've gathered and really boil them down. We want to give you the key information you need to understand this condition clearly without getting totally overwhelmed.
Absolutely. We'll unpack what it is, what kicks it off, who's more at risk,
The actual process in the body, how doctors figure it out,
how common it is, the telltale signs, the tests needed.
how it's managed, the prognosis, and the potential complications down the line.
Hopefully we'll connect some important dots for you.
Let's start with the absolute basics then. What exactly is ascending cholangitis?
So, simply put, it's an infection and inflammation happening inside those bile ducts we mentioned.
Okay.
And remember, their main job is carrying bile. The usual trigger, as you said, is some kind of obstruction that stops the bile flowing. It just sits there, stagnates, and becomes a perfect breeding ground for bacteria.
Got it. So blockage leading to infection, that's the core issue. Now, what typically causes this blockage that then lets the infection happen?
Well, the main mechanism is bacteria, usually the ones that live quite happily in your intestines, managing to travel upwards into the bile ducts.
So they're going the wrong way up the pipe, basically.
Exactly. Normally, bile flow keeps them flushed out, but with a blockage, they can migrate up. The usual suspects, bacterium-wise, are things like Klebsiella, E. coli, which most people have heard of, Enterobacter, Enterococci, and Streptococci. Kind of the usual gut gang causing trouble elsewhere.
Okay, so our own gut bacteria turning problematic when they get into the wrong place.
Yeah.
Are there any less common causes?
Yeah, in some parts of the world, parasitic infections like roundworm or liver fluke can be the culprits.
Interesting.
But generally, the underlying issue is still that blockage stopping the normal flow.
So what actually causes the blockages themselves? You mentioned gallstones.
Gallstones are definitely the most common cause,
Hey,
by far.
they pop up everywhere, don't they?
They really do. But it's not just stones. Tumors can also block the ducts.
Okay, like what kind of tumors?
Think pancreatic cancer or cancer in the bile ducts themselves. That's cholangiocarcinoma. Also, tumors where the bile and pancreatic ducts meet, called ampullary tumors, or even liver tumors pressing on the ducts from the outside.
Wow, okay.
Then you have strictures, which are just narrowings of the ducts.
Anything that makes the pipe tighter.
Exactly. Also, something called a Choledochal, which is like a little cyst or bulge in the common bile duct. And there's a specific condition called AIDS cholangiopathy, and as we mentioned, those parasitic infections.
Right.
And interestingly, even a procedure called ERCP,
What's that?
it's endoscopic retrograde cholangiopancreatography, basically using a scope to look at the bile and pancreatic ducts. Sometimes, though not often, that procedure itself can actually trigger cholangitis.
Huh. So quite a few potential roadblocks there. Given all that, who is more likely to develop ascending cholangitis? What are the main risk factors?
Well, the risk factors really echo the causes of the blockages we just talked about. So having gallstones is a major one, reinforcing that link.
Makes sense.
Also, people who've had surgery on their bile ducts before, or maybe they have biliary stents already in place, they're at higher risk too.
Right, because the normal anatomy or flow has already been altered, I suppose?
Precisely. Existing biliary strictures are another risk factor, as are tumors in that whole biliary system. And again, those parasitic infections, particularly in endemic areas. And finally, having had medical procedures involving the bile ducts, especially ERCP, does carry a small increased risk.
Okay, so we understand what it is that causes the risks. Let's get into the nitty-gritty, the pathophysiology. What's the actual chain of events in the body when this develops?
Right, so it really kicks off with that blockage. This creates, essentially, stagnant bile, a perfect little incubator for bacteria.
Like a warm pond for germs.
Exactly. And because the flow is stopped, bacteria from the intestine can then multiply and, crucially, ascend or travel upwards into the bile ducts. It's like traffic backing up and allowing cars to go the wrong way down a one-way street.
Okay.
Once these bacteria are up there in the ducts, they cause infection and inflammation. The body naturally reacts to this invasion by releasing inflammatory chemicals to fight the infection.
Which sounds like a good thing.
It is, initially, but this inflammatory response itself can actually damage the lining of the bile ducts and the surrounding liver tissue.
Ah, so friendly fire almost.
Sort of, yes. And if this whole cycle isn't stopped, if it's not treated promptly, the infection can escalate. It can spill into the bloodstream, causing sepsis, which is a massive body-wide inflammatory response that can be really dangerous, even life-threatening.
That sounds incredibly serious. Early diagnosis must be key then. When someone comes in with symptoms that might be cholangitis, what other conditions could be causing similar signs? What's on the differential diagnosis list?
Yeah, that's a really important point. Several conditions can mimic ascending cholangitis, so doctors need to be careful. Key things to distinguish it from are gallstones causing pain without the infection, or cholecystitis, which is inflammation of the gallbladder itself, related but different.
Okay.
Then there's diverticular disease, which affects the colon but can cause abdominal pain. Various types of hepatitis, viral, drug-induced, can cause jaundice and pain. Mesenteric ischemia, where blood flow to the gut is compromised, is another one.
So quite a few possibilities just within the digestive system.
Definitely. Pancreatitis is also high on the list, especially since the pancreas and bile ducts are so closely linked. And sometimes symptoms might be due to other causes of septic shock, not necessarily originating in the bile ducts.
Right.
For patients with known liver issues, you'd also think about complications of cirrhosis or acute liver failure. A liver abscess, which can sometimes be a complication of cholangitis, could also be the primary issue. And even things like acute appendicitis, a perforated peptic ulcer, or a kidney infection, pyelonephritis, need to be ruled out depending on the exact symptoms.
So a thorough workup is essential to pinpoint the cause. Let's talk about how common this is, specifically looking at the UK context on the epidemiology.
Okay. Well, in the UK, studies suggest that acute cholangitis might be involved in up to maybe 9% of hospital admissions related to gallstone disease.
That's not insignificant.
No, it's not. And related to that procedure we mentioned, ERCP, the rate of developing cholangitis afterwards is estimated to be around 1%.
Okay. And are there patterns in who gets it?
There's definitely a link to gallstone prevalence. So it tends to be more common in populations where gallstones are more frequent. Think fair-skinned people of Northern European descent, Hispanic populations, Native Americans, Pima Indians.
Right.
Interestingly, though, it seems to affect males and females pretty equally, and the typical age when people present is usually somewhere in their 50s or 60s.
And you mentioned tumors earlier as a cause. How often is cancer involved?
Estimates vary, but it's thought that somewhere between 10 and 30% of cases of acute cholangitis might have an underlying malignancy causing the blockage.
Like cancers of the bile duct, gallbladder.
Exactly, or pancreas, ampulla, even the duodenum sometime. It really highlights why finding the cause of the blockage is so critical, not just treating the infection.
Absolutely. Okay, let's move on to the clinical picture. What does a patient with ascending cholangitis actually look and feel like?
Yeah.
What are the key signs and symptoms?
The absolute classic presentation is something called Charcot's triad. This is really, really key to remember for exams and practice.
Okay, Charcot's triad. What is it?
It consists of three things: fever, right upper quadrant abdominal pain, so pain in the top right part of the belly, and jaundice, that yellowing of the skin and eyes.
Fever, right upper quadrant pain, jaundice. Is there a mnemonic for that?
Yeah, a simple one is just think FRJ. Fever, right pain, jaundice, feeling rough, right pain, yellow, whatever, helps you lock it in.
FRJ. Got it. Feeling rough, right pain, yellow. That works. Does everyone with cholangitis have this triad?
Not everyone, but it's present in a good chunk of patients, maybe 50 to 70%.
Okay. What other symptoms might show up?
People might also get chills or rigors, those really intense teeth-chattering shivers, a general feeling of malaise, just feeling really unwell. Nausea and vomiting are common too.
And are there signs if it's particularly severe?
Yes. If things are really bad, you might see something called Reynolds pentad. That's Charcot's triad, the FRJ-PLUS, two more worrying signs. Hypotension, meaning dangerously low blood pressure, and altered mental status, confusion, drowsiness, just not being quite right.
So FRJ plus low BP and confusion equals Reynolds pentad, and that's a sign of serious trouble, like sepsis.
Exactly. Reynolds pentad indicates a much more severe infection, often with septic shock and organ dysfunction starting. It's a real medical emergency.
How often do you see that full pentad?
Thankfully, it's less common than the triad, maybe around 10 to 20% of cases present with those severe signs. It's also worth noting that older patients might not have that classic sharp RUQ pain. It might be more vague or poorly localized.
Right. And you mentioned severity. Doctors actually grade it.
Yes, there are severity grades, usually mild grade 1, moderate grade 2, and severe grade 3. This grading is based on signs of organ dysfunction and helps guide how urgently treatment like drainage is needed.
Okay. What other clues might a doctor look for, either from the patient's history or the examination?
Well, sometimes patients might mention colic stools that's pale, clay-colored poo because bile isn't reaching the gut properly.
Lack of bile pigment.
Exactly. And pruritus, which is intense itching, can happen because of the bile salts building up in skin. Getting a good history is vital, asking about previous gallstones, common bile duct stones, any prior biliary surgery or ERCPs. Even things like HIVs can be relevant due to AIDS cholangiopathy.
Right. And on physical exam.
You'd look for fever, obviously, tenderness when pressing on that right upper quadrant, visible jaundice. Checking their mental status is crucial, especially if you suspect severity, and monitoring blood pressure and heart rate for signs of shock, low BP, fast heart rate.
So putting it all together, history, symptoms, exam, how do doctors formally diagnose it? Are there specific criteria?
Yes, there are diagnostic criteria, usually based on guidelines like the Tokyo guidelines. They combine clinical findings, lab results, and imaging.
Okay.
So a suspected diagnosis might be made if someone has, say, 2 or more clinical items like a history of biliary disease, fever chills, jaundice, or that RUQ pain.
And for a definite diagnosis?
For a definite diagnosis, you typically need either the full Charcot's triad or 2 of those clinical items we just mentioned, plus evidence from blood tests showing inflammation and cholestasis, like high white cells, high CRP, abnormal LFTs, and imaging evidence of bile duct dilation or a cause like a stone or stricture.
That sounds quite specific. How are the severity grades defined using these criteria? Like, what makes it severe?
Severe cholangitis, grade 3, is generally diagnosed when there's evidence of organ dysfunction associated with the cholangitis. This could be cardiovascular issues, like needing medication to support blood pressure, neurological problems like confusion, respiratory failure, kidney injury, liver problems beyond the cholestasis, or blood clotting issues.
So signs that major body systems are struggling. What about moderate?
Moderate cholangitis, grade 2, is kind of the middle ground. It doesn't meet the criteria for severe, but it's worse than mild. It's often defined by having 2 or more factors like a high white blood cell count, e.g. 12,000 or 4,000, a high fever like 39 degrees C, being older, for example, 75 years, having significantly high bilirubin, for example, of 5 milli-GDL, or low albumin levels in the blood.
And mild grade 1 is everything else that meets the diagnostic criteria, but isn't moderate or severe.
Exactly. And these grades are really important because they directly influence the management plan, especially how quickly you need to drain the bile ducts.
Okay, that makes sense. So once ascending cholangitis is suspected or confirmed, what investigations are absolutely crucial? What tests do you need?
Right, investigations are key. You'll definitely need blood tests. A full blood count, the FBC, is standard. You're looking for a raised white blood cell count, often with more neutrophils. That's your classic sign of bacterial infection. Think infection fight, actually high WBC. Liver function tests, LFTs, are critical. You expect to see a cholestatic picture, meaning the bile flow is blocked. So you'll see elevated alkaline phosphatase, ALP, and gamma-GT, GGT, along with raised conjugated bilirubin. Assessing overall liver synthetic function is important too.
So ALP, GGT, bilirubin, upthink, bile flow blocked. Makes sense.
Exactly. You'll also check inflammatory markers like C-reactive protein, CRP, and maybe ESR. These will typically be high.
Okay.
Kidney function tests, UNEs, or urea and electrolytes, and clotting screen are important to assess for any organ damage or complications like coagulopathy. And crucially, blood cultures, you need to take these before starting antibiotics if possible to try and identify the specific bug causing the trouble.
So you can target the treatment later. Anything else blood-wise?
Amylase might be checked too. It can be raised if the blockage is low down near the pancreas. And if a biliary stent is removed during a procedure, sending that or a bile sample for culture can be really helpful.
Okay, that covers the bloods. What about imaging? How do you see what's going on inside?
Imaging is absolutely vital. The first-line test is usually an abdominal ultrasound. It's quick, non-invasive, and pretty good at showing if the bile ducts are dilated, and it can often spot gallstones in the gallbladder or sometimes in the ducts.
So start with ultrasound. What if that's not clear or doesn't show much?
If the ultrasound is normal or inconclusive, but you still strongly suspect cholangitis, then a CT scan of the abdomen might be next. CT can also show duct dilation, sometimes better than ultrasound, and might pick up strictures or masses.
Okay. What about more specialized imaging? We hear about MRCP and ERCP.
Right. MRCP, magnetic resonance cholangiopancreatography, is a type of MRI scan that gives really detailed pictures of the bile and pancreatic ducts. It's excellent for diagnosis, showing stones, strictures, dilation very clearly, and it's non-invasive. It's often used when ultrasound isn't definitive.
So MRCP is great for looking. What about ERCP?
ERCP, endoscopic retrograde cholangiopancreatography, is kind of the gold standard, especially because it's both diagnostic and therapeutic.
Ah, so you treat at the same time.
Exactly. Using an endoscope, they can inject dye to see the ducts, diagnostic, and then, importantly, they can remove stones, dilate strictures, or place stents to relieve the blockage and allow the bile to drain, therapeutic. It's often the go-to if MRCP isn't feasible or if urgent drainage is needed based on high bilirubin or strong clinical suspicion.
Is there anything else? What about endoscopic ultrasound? EUS.
Yes, EUS is another useful tool. It involves an ultrasound probe on the end of an endoscope, getting really close to the bile ducts from inside the stomach or duodenum. It's very good for spotting small stones or tumors. It can be an alternative if MRCP isn't possible, or sometimes if LFTs are normal but you still suspect a stone, or if the risk of ERCP is considered high, like in pregnancy. EUS can sometimes be used therapeutically, too, for drainage in certain situations.
Lots of options there. So you've done the test, confirmed ascending cholangitis. What's the management plan? How do you treat it?
Okay, first and foremost, ascending cholangitis is a medical emergency. Time is critical. The core principles are supportive care, antibiotics, and crucially, relieving that biliary obstruction, getting the bile flowing again.
Let's break that down. Supportive care.
That means basics like intravenous fluids, often lots of them, to rehydrate the patient and support their blood pressure, especially if they're heading towards sepsis. Correcting any electrolyte imbalances. Managing pain, and correcting any clotting problems, maybe with vitamin K or clotting factors if needed.
Okay, and antibiotics.
Absolutely essential, and started promptly. Usually, broad-spectrum intravenous antibiotics are given right away, ideally after blood cultures have been taken. You need cover for those common gut bacteria we mentioned, gram-negatives, and often anaerobes too.
So hit hard and wide initially.
Yes, then you can tailor the antibiotics later if you get specific culture results back.
And the most critical part, relieving the blockage.
Yes, biliary decompression or drainage. This is usually done endoscopically via ERCP. That allows removal of stones or placement of a stent to bypass the blockage.
How quickly does that need to happen?
It depends on the severity. For severe grade 3 cholangitis with organ dysfunction, emergency drainage within 24 hours or even sooner is vital. For moderate grade 2, early drainage, maybe within 24-48 hours, is usually recommended. For mild grade cases that respond well to antibiotics, drainage might be done less urgently or electively later.
And if ERCP isn't possible or fails?
Then you need alternatives. Percutaneous transhepatic cholangiography, or PTC, involves putting a drainage tube through the skin into the liver's bile ducts under imaging guidance. Sometimes EUS-guided drainage is an option, or in some situations, surgical drainage might be necessary.
What about intensive care?
Patients with severe cholangitis, especially those with Reynolds pentad or signs of organ failure, will definitely need admission to an intensive care unit or high-dependency unit for close monitoring, fluid resuscitation, potentially support for breathing or blood pressure, and managing all the complications of sepsis.
Okay, so you treat the infection, drain the blockage. What happens long-term, especially if gallstones were the cause?
That's a key point. If gallstones cause the cholangitis, once the acute infection has settled and the patient has recovered, a cholecystectomy, surgical removal of the gallbladder, is usually recommended.
Why is that?
Because the risk of having another episode of cholangitis or other gallstone complications like pancreatitis is really high if you leave the gallbladder and the stones in place. So removing the source is important for preventing recurrence. This is usually done electively a bit later once things have calmed down.
Makes perfect sense. Get rid of the factory producing the stones. Now, what's the overall outlook? What's the prognosis for someone with ascending cholangitis?
Generally, with prompt diagnosis and appropriate treatment, meaning antibiotics and timely biliary drainage, the prognosis is actually quite good for many patients.
Okay.
But if treatment is delayed or if the patient is very unwell to begin with or has underlying issues, the outcome can be much worse. Untreated or delayed treatment significantly increases the risk of serious complications like widespread sepsis, liver abscesses forming, or long-term damage like bile duct strictures.
So promptness is key.
Absolutely. The prognosis really depends on the severity of the illness at presentation, what caused the blockage, for example, versus malignancy, the patient's overall health and age, and how quickly effective drainage is achieved.
What about mortality rates?
Historically, mortality was quite high, but with modern management, including early ERCP and better critical care, it's improved a lot. However, it can still vary significantly. Figures often quoted range somewhere between, say, 5% up to maybe 17% or even higher in some series, particularly for severe cases, elderly patients, or those with underlying cancer. Early endoscopic drainage, once the patient is stabilized, definitely improves outcomes.
Are there specific things that predict a worse outcome?
Yes, certain factors are known to be associated with a poorer prognosis. Things like having hypoalbuminemia, low protein levels in the blood, a prolonged prothrombin time, or high INR, indicating clotting problems, very high bilirubin levels, high fever, or a very high white cell count on admission. Advanced age is often a factor, low blood pressure or shock, high CRP levels, and perhaps obviously failure to respond quickly to initial antibiotic treatment or having an underlying malignancy as the cause of the blockage. These suggest a tougher course.
Okay, that gives us a good idea of the outlook. Finally, let's touch on the potential complications. If things don't go smoothly, or if the condition is very severe, what can go wrong?
The complications can be pretty serious, unfortunately. Sepsis is the big immediate worry, and that can spiral into septic shock and multi-organ failure affecting the kidneys, lungs, brain, clotting system.
Right.
A liver abscess can form, which is a collection of pus in the liver, often resulting from the uncontrolled infection. Chronic inflammation from repeated or severe episodes can lead to biliary strictures, which are scarring and narrowing of the bile ducts, causing problems long term.
What else?
Pancreatitis can be triggered, especially if the blockage is low down near the pancreatic duct opening. And as mentioned, acute kidney injury and liver failure can occur as part of multi-organ dysfunction in severe sepsis.
Are there longer-term issues too?
Yes, some people can suffer from recurrent episodes of cholangitis, especially if the underlying cause isn't fully dealt with, like retained stones or persistent strictures. This can lead to chronic cholangitis and eventually even biliary cirrhosis, which is irreversible scarring of the liver due to the ongoing bile duct problems.
And the drainage procedures themselves, like ERCP, can they have complications?
Yes, any invasive procedure carries risks. With ERCP, potential complications include pancreatitis, bleeding, perforation of the bowel or bile duct, and infection. With percutaneous drainage, PTC, risks include bleeding, bile leakage, infection or sepsis, and injury to surrounding structures. So these procedures are essential, but not entirely without risk.
So it really underscores why catching and treating this condition early is so vital.
Absolutely. The King message is, ascending cholangitis is a serious infection, usually caused by a bile duct blockage. Recognizing the signs, especially that FRJ triad or the more severe Reynolds pentad, getting the right investigations quickly, bloods, and imaging, and starting treatment promptly with antibiotics and, crucially, biliary drainage, is essential to prevent these potentially life-threatening complications and ensure the best possible outcome.
It really does highlight how a seemingly simple plumbing problem, a blockage, can cascade into a major systemic infection and inflammatory crisis.
It really does. It's a stark reminder of how interconnected everything is in the body and how quickly things can go wrong when a key system is disrupted.
Well, that wraps up our deep dive into ascending cholangitis. We hope this breakdown has been clear and helpful, especially if you're revising this topic.
Yes, hopefully distilling those key facts helps.
And if you are looking for more in-depth MSRA revision materials and resources, do check out pastthemsra.com and freemsra.com.
Great resources there.
Thanks for joining us on the Deep Dive.